I would like to invite Professor Dr. Gopinathan to give his talk on spino-pelvic alignment in THR, reducing the gap between spine and hip surgeon.
Yeah, but it looks a little bit tighter. Take this off. What happens is, if we are more experienced, we can manage. Yeah, external.
So friends, very important topic and burning topic now, spinopelvic parameters. It's very,
Actually looks
little
okay.
tricky topic,
This thing is
so
also
you
closing.
must listen it carefully, and Dr. Gopinath presents it so nicely. So if you listen carefully, you can understand, at least you can apply whenever a patient with spinal fusion comes to your clinic. Over to Dr. Gopinathan, please.
Respected dignitaries, honored after us, my dear friends and colleagues. First of all, I thank everyone who are assembled over here for this particular meeting. I think we have more than 300 registrations, and I hope you are enjoying this program well. So what is important today is that you have to study something about the spino-pelvic alignment and spino-pelvic mechanisms for hip reconstruction. Because if you don't learn about this in every meeting, it's one of the hottest topic, and one session will be on that. So if you say that it is very important, it is only very simple, and then people may think that you are not up to the mark, up to the day. So what's important to understand is that spine and the hip, when you talk about, the pelvis should be considered as part of spine. Now that's the concept, not that the pelvis is part of lower limb. So pelvis is considered as one vertebra. So you have so many sagittal plane problems you can get. You can either get a neutral plane, you can get a kyphosis, or you can get a lordosis. So when you have a kyphosis, your pelvis has to go back. So kyphosis means spine is bent forward. So pelvis tilts like this. So in ankylosing spondylitis, really happens that when spine tilts forwards, when you stand up, the pelvis tilts back. The moment pelvis tilts back, the hip has to go into flexion. So if the patient tries to extend the hip, it will not happen. So they develop what is known as a universal flexion. So when the hip goes in for flexion, knee will go for flexion, and the patient walks like this. He cannot walk like this, not because the hip is abnormal, just because the spine is abnormal. So this intimate relation has to be studied if you want to do a good THR. So if you do THR in such a patient where there is a kyphosis, the pelvis is fixed like this, and if you put the stem and the cup, as in any other case, what will happen is the moment the patient extends the hip, there will be a posterior impingement, anterior edge loading, and anterior dislocation in standing position. It's going to happen. So the idea of this talk is how to reduce it. Now suppose you talk about a reverse condition, a patient with exaggerated lumbar lordosis, then that patient when sits, the pelvis is tilted always anteriorly. Now the moment you sit, the pelvis has to tilt back. That's why you get more flexion. You can try yourself now. You sit back and try to flex your hip. You sit straight and try to flex your hip. The moment you sit back, the pelvis is rotated or tilted backwards. That is open up the acetabulum very much. The moment the open up the acetabulum happens, that means anteversion has increased. So when the anteversion is increased, there is no anterior impingement. The pelvis has opened, acetabulum has opened up anteriorly so much so that you will get more flexion. So it's a normal mechanism. When you stand up normally, you get the lumbar lordosis. The pelvis tilts anteriorly. This is a normal mechanism. Unless you learn the normal mechanism, you cannot learn the abnormal mechanism. So I'll repeat again. When you sit down with a relaxed spine and sit on relaxed like this, then your lumbar lordosis disappears. The moment lumbar lordosis disappears, the pelvis tilts back. When the pelvis tilts back, the acetabulum opens up. It gives you more flexion. It's a normal mechanism. And when you stand up, the lumbar lordosis returns, the pelvis tilts anteriorly, and the flexion you get is less. But when you do like this, you get more flexion. This mechanism you should understand. And so when there is a fixed lumbar lordosis, the pelvis is tilted anteriorly. When you sit, you cannot get relaxed. It never goes posteriorly. So when the pelvis is tilted anteriorly like this, what will really happen is there is an anterior impingement when you sit, and there is a posterior edge loading and posterior dislocation. Just reverse of ankylosing spondylitis. So this basic mechanism, if you can understand, then it is easy to learn the spinopelvic alignment and spinopelvic mechanism. So you want to avoid the anterior impingement in sitting position. That means you have to increase aversion. You want to reduce the posterior impingement in standing position, you have to reduce aversion. So in a fixed lumbar lordosis with a fixed anterior pelvic tilt, you have to increase aversion. That point is clear? When you have a pelvis which is tilted anteriorly in standing position, for example, it is in standing position anterior tilted, that is normal, that you will not do any adjustment for that. But if the pelvis is tilted posteriorly in standing position, that means in that case you have to reduce aversion. So this is what you should know. If there is a pelvis, I can show how is it in the after next few slides. So this is about the sagittal plane anomalies. Now you can have a in the lateral position. You can this sagittal position I have talked about. Now you have a kyphosis and exagittal lumboid. This also I have talked about. Now this is what you expect in a normal after normal hip replacement. But this will not replicate everything. This is just a radiological measurement. When it is parallel, you cannot say that everything is all right. So what really happens in lateral decubitus position? So this all positions can happen. When you position the patient, according to the spinal problems, the pelvis can be in the anterior plane, in the neutral plane, or in the posterior plane, which is difficult for you to assess on the table. Now, when you have fixed pelvic obliquity, what really happens is you have an adducted side and an abducted side. This is not due to a hip deformity. I am talking about a spine deformity. So when you orient the cup the same way in both positions, you are wrong. So if you are operating an abducted side with an adducted side downs, then you have to give the cup in more close position. If you do the other way around, you put the abducted side on the other side, try to operate the adducted side, you can reduce the inclination. So this point you should understand. So the pelvic obliquity, the cup position is very hard.